Hello and welcome to Veterinary Instrumentation's latest episode of Under the Skin, a videography and animation series introducing key devices and techniques used during orthopedic surgery. In this episode, we're looking at how a dynamic locking plate, or DLP, is used as a bridging plate for stabilization of a comminuted fracture. So, let's go under the skin. A DLP, with its distinctive figure-of-8 shaped holes, can be used in numerous ways, depending on the type of fracture being treated and the desired surgical result. A DLP allows a surgeon to choose between a locking or a non-locking screw at each hole. Each figure-of-8 shaped hole has a threaded end to accept a locking screw. The other end is a non-threaded oval hole of the same design as a DCP plate hole. Locking technology offers a very secure plating construct. The threaded screw heads lock into the threaded plate holes, creating a rigid, angle-stable construct. Where axial compression is not appropriate or achievable, the DLP can be used in purely locking mode as a neutralization or bridging plate. Locking screws can also be placed as monocortical screws, as they are angle stable, which may be useful when working close to a joint. The DLP can be used in bridging mode when repairing a non-reconstructable comminuted mid-diaphyseal fracture. The most common and practical way of using a DLP as a bridging plate would be as a plate rod construct, which uses the DLP combined with an intramedullary pin. The IM pin has multiple advantages. It extends the fractured bone to the correct length, it holds the bone stable whilst the DLP is applied, and it complements the plate mechanically as it has very strong resistance to bending forces. The plate bridges the fracture fragments and maintains the bone in alignment, allowing the fracture to heal by callus, also called secondary bone healing. A bridging plate construct, including the IM pin which resists bending, must be strong enough to resist all the forces of weight bearing until the bone has healed, as there will be no load sharing with the bone during the early phases of fracture healing. Specific equipment is required for using a DLP in this way, and all equipment must be appropriate for the size of implants being used. A pilot drill, a locking screw drill guide, a depth gauge, bending levers, a screwdriver. Other videos in this series have described the use of the depth gauge and the bending levers. A Jacob's chuck or powered drill is also required for insertion of the IM pin. Powered insertion is preferred for accuracy of pin position and direction. The IM pin should be of an appropriate size to the patient, filling approximately 30 to 50% of the medullary canal at its narrowest point mid-diaphysis. Norma-grade insertion of an IM pin is preferred as it gives better control of the bone entry point. Holding the proximal segment of the femur using the bone-holding forceps, the pin is walked off the greater trochanter medially until it drops into the trochanteric fossa. It is then driven gently into the bone, directed parallel to the long axis. Resistance will be felt at first, but the resistance should drop once the pin has fully penetrated the cortical bone of the trochanteric fossa. The pin is then driven down the medullary canal until the tip protrudes at the fracture site. The trocar tip of the pin can be cut at this stage if the surgeon is concerned about distal penetration into the stifle joint. The distal end of the femur is then grasped using bone-holding forceps. It is aligned with the proximal end of the femur, and the IM pin is driven across the fracture and into the distal segment. The IM pin is then driven carefully until the bone is seen to extend to the correct length, and until the pin is seated in the cortical bone of the distal femur. Great care must be taken not to drive the pin too far in order to avoid penetration of the distal femur into the stifle joint. A second IM pin held on the outside of the limb as a comparison allows the surgeon to check length and positioning. A DLP used as a bridging plate in purely locking mode needs only approximate contouring. However, if a combination of screws are to be used, or only non-locking screws, then perfect plate contouring is essential. Performing approximate rather than perfect contouring can save time during surgery. It also allows the DLP to be applied using minimally invasive surgical techniques where appropriate. The plate should be as long as possible, and positioning and contouring should be checked prior to fixation. Temporary fixation of the plate to the bone will be helpful, achieved either using plate or bone holding forceps, or a K-wire drilled into the bone through a locking wire guide. Once the plate is appropriately positioned, the first pilot hole is drilled. The locking screw drill guide is used to ensure a perfect 90-degree angle of the pilot hole relative to the plate hole. This device must be used for every locking screw. The first screw for a bridging plate will usually be applied at one end of the plate. The locking screw drill guide is then removed, and the depth of the pilot hole is measured using the depth gauge to ensure selection of the appropriate length of screw. The locking screw is placed in the usual manner. The exact order of screw placement for a bridging plate is not prescriptive, but the norm would be to work far to near. In other words, starting at either end of the plate and working in towards the fracture. It is, however, very important that the screws are placed as far from the fracture as possible, in order to distribute bending forces over as much of the plate as possible. 3 or 4 screws at each end of the plate would usually be sufficient, and when using locking screws, it is possible to place the furthest screw monocortically if required, for example to avoid joint penetration. Once the plate is secured, the proximal end of the IM pin can be bent laterally and cut, or just cut, using an appropriate implant cutter. The pin must be cut as low and as close to the greater trochanter as possible. For further information on the VI range of instruments and implants for internal fixation, please visit our website or contact our specialist technical support team. Join our online community by following our social media pages, keeping up to date with the latest releases of training and education material, as well as company updates.